Dear students, in this journey of ongoing video lectures, today we'll be talking about diabetes mellitus. As you all know, that diabetes mellitus is one of the most common metabolic disorders encountered in today's life because of varied factors like stress, hypertension, and obesity acting as cofactors in the development of this disease. So as we go on through this journey of diabetes, I'll be having this type of plan of talk in which we'll be talking about the definition, the criteria, the classification, and the pathogenesis of type 1 diabetes mellitus. Now, we need to understand that diabetes is not a single disease, but it is a group of metabolic disorders that share the common underlying feature of hyperglycemia. What is hyperglycemia? Hyperglycemia is increased level of sugar in the body, or in the medical terms, increased plasma glucose. This can be because of two factors. Either there is a defect in insulin secretion. Insulin is the most important hormone that regulates the glucose homeostasis. Either there is a defect in insulin secretion or there is a defect in insulin action. What do you mean by insulin action? Insulin action is the combination of insulin with the insulin receptors on the fat cells, on the muscles, on the different peripheral organs of the body, through which it acts to control the sugar. So either there is a deficit or a defect in insulin secretion, or there is a defect in insulin action, or both. Now, this diagram shows you that pancreas is a retroperitoneal organ. It has the pancreatic duct and the bile duct that open into the duodenum. Now, according to the ADA is the American Diabetic Association. Following are the criteria for diagnosis of diabetes mellitus. First is a fasting plasma glucose level of more than 126 milligram per deciliter, repeated on the second day, that is 2 subsequent values. Second is a post-meal or a 2-hour plasma glucose more than 200. And more reliable is HbA1c more than 6.5%. HbA1c. A1c is a type of a hemoglobin that allows the plasma glucose to be monitored over the previous 8 to 12 weeks. When we say fasting plasma glucose, what do you mean by fasting? That is not having eaten any food for the past 8 to 12 hours. That is fasting plasma glucose. OGGT, that is oral glucose tolerance test, is not recommended for routine use. It is mostly used in cases of gestational diabetes mellitus. Now, impaired fasting glucose. Impaired fasting glucose is an alarm bell for an upcoming diabetes mellitus. When the fasting glucose is more than 100 or less than 126, or if the oral glucose tolerance level at 2 hours is more than 140 but less than 200. Now, these are the criteria for diagnosis in non-pregnant adults. The same: random plasma glucose with classic symptoms more than 200, fasting plasma glucose more than or equal to 126 milligram per deciliter, more than 200 milligram deciliter 2-hour plasma glucose after a 75 grams glucose load, or all of these are to be confirmed on the subsequent day. Now, whom are the people that we need to test on? First of all, any asymptomatic normal person more than 45 years should be tested every 3 years, or young individual but obese, HDL cholesterol, that is the good cholesterol, less than 35, triglyceride or the bad cholesterol more than 250, a previous impaired glucose tolerance, or a first degree relative with diabetes mellitus, or a lady who has delivered a baby weighing more than 9 pounds. In the routine screening of diabetes patients, it should include albuminuria, that is measurement of albumin in the urine. In case if albumin is negative, microalbuminuria should be measured, along with lipid profile, renal function, especially for nephropathy, because diabetic nephropathy is one of the most important complications of diabetes mellitus. Now, just a small discussion of gestational diabetes mellitus. Gestational diabetes mellitus is very important because it is needed for screening all pregnant women, because in case if gestational diabetes is not controlled, it leads to fetal morbidity. In gestational diabetes, the random blood glucose level after ingestion of 50 gram of glucose at 24 to 28 week of gestation, if the values are more than 140 milligram per deciliter, it is indication for a 3-hour 100 gram glucose GTT. How do you diagnose gestational diabetes? Fasting more than 95, 1 hour glucose load more than 180, at 2 hours more than 155, and at 3 hours more than 150. Gestational diabetes mellitus, if there are abnormal results during pregnancy, repeat this test at the first postpartum visit. If it is normal, then it is only diabetes mellitus during pregnancy. But in case if it is more, then there is a 30% risk in the next 5 to 10 years for developing diabetes mellitus. Now, diabetes mellitus can be classified as either type 1 or type 2. Type 1, also known as insulin dependent diabetes mellitus, that is, the predominant factor in type 1 is an insulin deficiency. So these patients only survive when insulin is given externally. Hence it is insulin dependent diabetes mellitus, also known as autoimmune diabetes mellitus. Why? Because autoimmunity is the key factor in destroying the beta islet cells in type 1. Type 2 has two factors. There is not absolute deficiency, there is relative deficiency of insulin along with a combined insulin resistance. Hence, it is known as type 2 diabetes mellitus, also known as non-insulin dependent diabetes mellitus, NIDDM. Type 1 is more common in children, hence also at times known as juvenile onset diabetes mellitus. And type 2 is more common in adults and also known as adult onset diabetes mellitus. Before we proceed, it is very important that you understand the glucose homeostasis. Only if you have an understanding of the glucose homeostasis will you be able to understand why insulin causes diabetes. Plasma glucose is tightly regulated by the following hormones, most important insulin. Insulin leads to reduction in plasma glucose. Why? Because it leads to the peripheral uptake of glucose by the fat cells, the skeletal muscles and the different organs of the body. Glucagon, epinephrine, cortisol, growth hormone, they increase plasma glucose. Now, insulin action. The most important stimulus for insulin synthesis and release is glucose itself. The moment we consume sugar, any kind of sugar, this is the stimulus for synthesis as well as for release of insulin. Insulin is the most potent anabolic hormone. It leads to lipid, protein and glycogen synthesis. What is anabolism? You have come across these two terms of anabolism and catabolism. Catabolism is breakdown and anabolism is making. So it is a potent anabolic hormone. Insulin increases the rate of glucose transport in certain cells, hence leads to increased source of energy. Skeletal muscles, the myocardial cells, the adipose cells, and most important, glucose uptake in the brain is insulin dependent. Hence, neuroglycopenia, that is deficient glucose in the brain, leads to fainting attacks, and if it continues for long, can lead to vasovagal syncope and at times death of the patient. Now, coming on to etiology of type 1 diabetes or immune mediated diabetes mellitus, it's an autoimmune disease, that is, antibodies are secreted against self-antigens. There is selective destruction of the beta cells of the pancreas by the T cells, that is the T lymphocytes, and there are also circulating antibodies against the B cells. There are two factors. T cells are directly destroying the beta cells, and also there are antibodies that are combining with the beta cells and destroying it. Cause of autoimmunity is usually unknown, and genetic and environmental factors have been put forth. I have just put this diagram of type 2 diabetes so that you can understand what is the difference between type 1 and type 2. Here in type 2 you can see there is impaired insulin action along with beta cell dysfunction and death. There is no absolute insulin deficiency. There is beta cell dysfunction, there is beta cell death that leads to impaired insulin secretion. But the most important factor in type 2 is impaired insulin action that leads to decreased glucose utilization in the fat cells and in the muscles and increased glucose production in the liver. In type 2, the response to insulin is decreased. Hence, there is decreased glucose uptake by the muscle and the fat where it should have been more, and there is increased glucose production in the liver where it should not have been taking place. The mechanism of insulin resistance is again unclear, and there are genetic and environmental factors implicated. Now, coming on to the most important part, that is pathogenesis of type 1 diabetes mellitus. That is, why does type 1 diabetes mellitus occur? As I've already told, autoimmune, there is pancreatic islet beta cell destruction predominantly by an autoimmune process. What is autoimmunity? Failure of self-tolerance is autoimmunity. Either antibodies are generated to destroy these beta cells, or the T cells directly destroy the beta cells. It usually develops in childhood or early adulthood, and it accounts for up to 10% of all DM cases, and it develops as a result of exposure of a genetically susceptible individual to an environmental agent. Now coming on to the genetic predisposition, HLA locus at chromosome 6p21 is considered now an important factor in an individual with such type of genetic predisposition. An event such as viral infection or intoxin can trigger the autoimmune destruction of the beta cells. Now, what are the environmental factors? Viral infection, mumps, rubella, Coxsackie, CMV, or you can have molecular mimicry or viral deja vu. What is viral deja vu? Deja vu in French means have already seen you. A viral infection once has occurred. Now, second time, these viral antibodies behave as if the body knows them, and these destruct the beta cells. You can see these are insulin producing cells around the blood vessels, and how the insulin producing cells are destroyed. There are 4 stages in the development of type 1 diabetes mellitus. One is preclinical period with positive beta cell antibodies, hyperglycemia and ketosis, when 80 to 90% of the beta cells are destroyed, transient remission and establishment of the disease. Now, this is the diagrammatic representation that shows you the stages in the development of type 1 diabetes. Now, in type 1, we have talked about the definition, the criteria, the insulin metabolism, and the pathogenesis. Now, coming on to type 2. Type 2 is a prototypic multifactorial diseases. Genetic factors may be involved, but there are 2 basic metabolic defects in type 2. Number 1, most important, a decreased response of peripheral tissues to insulin, that is insulin resistance. That is, there is insulin, but the receptors and the cells are not responding. Hence, these patients have hyperinsulinemia, whereas type 1 diabetes patients have hypo or absolutely no insulin in the body. And second, there can be beta cell dysfunction that leads to inadequate insulin secretion in the face of insulin resistance and hyperglycemia. That is, there is insulin resistance, there is hyperinsulinemia, there is hyperglycemia, along with inadequate insulin secretion. Now, this is a diagram that shows you the difference between diabetes type 1 and diabetes type 2, in which there is insufficient insulin, and here there is sufficient insulin, but there is insulin receptor, and it is the GLUT4 receptor that is mostly involved in the insulin resistance. It is the same diagram that I showed you earlier, that shows you that impaired insulin action is the important feature of type 2 diabetes. Now, the same thing. Response to insulin is decreased glucose uptake in the muscle and the fat, increased glucose production by the liver, and the mechanism of insulin resistance is unclear. Now, what is the mechanism of hyperglycemia in diabetes? In the absolute type, there is more hyperglycemia as compared to the relative type. There is an increase in the hepatic glucose output and a decrease in the peripheral glucose uptake. Do you understand now? Liver is producing more glucose and the peripheral tissues are consuming less glucose. So overall, what is going to happen? There will be an increased plasma glucose level. Now, in increase in hepatic glucose output, what happens? Whenever there is a decreased insulin, there is a decreased inhibitory effect on glucagon. Insulin inhibits glucagon. So if there is less insulin, there will be more glucagon, and this glucagon in the liver will stimulate gluconeogenesis and glycogenolysis that will lead to increased plasma glucose. Now, a decrease in glucose uptake in the muscle and in the adipose tissue. So, in the muscle, if there is decreased insulin, there will be decreased glucose and amino acid uptake, there will be increased protein breakdown, increased plasma glucose, and if in adipose tissue, if there is less insulin, there will be more lipolysis, less lipogenesis, and increase in plasma fatty acids. In type 2 diabetes, it results from insulin resistance with a defect in compensatory insulin secretion. Insulin may be low, normal, or high, and about 30% of type 2 patients are undiagnosed. What are the risk factors? Family history, obesity, habitual physical inactivity, hypertension, and hyperlipidemia. What is insulin resistance? Insulin resistance is defined as a failure of the target tissue to respond to insulin. This leads to decreased uptake of glucose in the muscle, reduced glycolysis and fatty acid oxidation in the liver, and inability to suppress the hepatic glycogenolysis. Obesity is absolutely related to insulin resistance. Why? Because in obesity there is a defect in insulin signaling pathway, and risk of diabetes increases as there is increase in body mass index. Central obesity or abdominal obesity is more linked with insulin resistance. Now, in obesity, excess of intracellular non-esterified fatty acids overwhelm the fatty acid oxidation pathways and lead to cytoplasmic intermediates, and these intermediates activate the serine threonine kinase that leads to aberrant phosphorylation of the insulin receptors that attenuate the insulin signaling. Attenuate means reduce the insulin signaling. And adipokines that are there in obesity are adipose cytokines, and they are of two types, pro-hyperglycemic, and they lead to an anti-hyperglycemic. But in obesity, the pro-hyperglycemic adipokines are more. In obesity, adiponectin levels are reduced that normally act by enhancing the activity of the AMP activated protein kinase, an enzyme that promotes fatty acid oxidation in the liver and the skeletal muscle, and hence leads to insulin resistance. Adipose tissue also secrete a variety of pro-inflammatory cytokines, and these cytokines also induce insulin resistance by increasing cellular stress, which in turn activate multiple signaling pathways. In obesity, peroxisome proliferator activated receptor gamma is a nuclear receptor that is expressed in the adipose tissue, and that when activated promotes secretion of anti-hyperglycemic adipokines. So nowadays recent research are concentrating on these adipokines, so that in case in obese patients, if anti-adipokines are generated, it can lead to decrease in blood sugar level. In type 2 diabetes, the beta cells initially secrete more insulin to compensate for that peripheral insulin resistance. But after a few years, they fail to secrete this more insulin. What happens as a result? There is peripheral resistance along with decreased secretion of insulin. There is also intrinsic predisposition to beta cell failure. Excess NEFAs also attenuate insulin signaling lipotoxicity, and these both predispose to insulin resistance as well as beta cell dysfunction. Amyloid resistance is a very characteristic finding in long-standing type 2 diabetes mellitus. These are islet amyloid proteins, and they are directly cytotoxic to islets, analogous to the Alzheimer's disease. So, type 2 diabetes mellitus is basically predominantly insulin resistance combined with dysfunction of the beta cells. There are no specific criteria for diagnosis, the same criteria as for type 1. Insulin resistance is a predominant factor. Obesity is one of the most important factors related to type 2 diabetes mellitus, especially central obesity, and the pathogenesis we have already talked about. Thank you. I hope in this short lecture of type 1 and type 2 diabetes, you could have at least a small bird's eye view what is the pathogenesis. Details, I request you all to go through the textbook of pathology, that is Robbins, and in my next lecture we'll be talking about the complications of diabetes mellitus. Thank you, children.